I'm Justin Davies from the Hammersmith Hospital in London. I'm at EuroPCR 2018 and I've been joined by David Kandzari, who's based at the Piedmont Institute in Atlanta. David, good afternoon and welcome.
Always great to be with you. Thanks, Justin.
Great, so it's been a great few days for us here at PCR.
It's been an exciting time indeed. In the PCR for these scientific sessions, we saw two studies, two sham-controlled trials performed in very different ways. One in the off-medication setting, this one that we're going to focus on in the on-meds indication, both showing a benefit and just overall amplifying or adding momentum to renal denervation therapy. And more specifically for the SPYRAL on-meds program, which we've presented at these scientific sessions, this was the second phase of the SPYRAL renal denervation program that you've been a big part of as well, where initially in the off-meds protocol, we demonstrated the biologic efficacy, the biologic proof of principle of renal denervation therapy in the absence of medications for uncontrolled hypertension. And the second parallel phase, which we've now presented, is the on-medications program, in which we evaluated renal denervation therapy in the context of commonly prescribed antihypertensive medications, but still with persistent uncontrolled hypertension. And this was the clinical scenario that many considered would be representative of clinical practice, in which we would perhaps one day, hopefully, integrate device therapies along with pharmacotherapies for uncontrolled hypertension.
So could you give us a 60-second snapshot of the key take-homes from the SPYRAL on study?
Certainly. Among 80 patients that were randomized evenly to a sham control procedure or alternatively renal denervation therapy, in short, renal denervation therapy was associated not only with statistically significant but clinically meaningful reductions across all blood pressure measures, and more specifically across 24-hour ambulatory blood pressure, systolic and diastolic measurements at 6-month follow-up, as well as office systolic and diastolic blood pressure measurements. And as an example, for the 24-hour ambulatory blood pressure assessment, the blood pressure with renal denervation was reduced 9.0 millimeters mercury relative to essentially no change, 1.6 millimeters mercury in the sham control group. This was a highly statistically significant difference. And further, we observed that with continued monitoring of blood pressure from 3 months and at 6 months with a 24-hour assessment that is, as you've written about, is a more accurate assessment of the burden of hypertension, we saw even a further progressive decline from 3 months to 6 months over that time period in both systolic and diastolic measures. And finally, we saw that over the 24-hour period alone, renal denervation was associated with a very persistent, constant reduction at all time intervals compared with the sham control group. And this has important implications that we can discuss for both how patients take or don't take their medicines, but also the limitations of pharmacotherapies, and especially may be relevant to selected patients with very high-risk features, such as those with nocturnal or early morning hypertension.
Thank you, David. How would you compare the SPYRAL on results with those of the SPYRAL off study, which has been presented before? Do they show the same thing, or do we know any more, or are they complementary?
That's a great question, Justin, and my short answer would be that they're very much complementary. So when we embarked on the off-meds protocol, the intent, as I shared, was really to demonstrate the biologic efficacy, and I'll be interested in your perspectives on this because it may have greater implications when we talk about non-adherence or patient preference to not take medications, as we've learned so much over these past 2 years. But with regard to the results, I think there are some remarkable consistencies. Number one, both studies demonstrate the safety of these procedures. We've seen no major adverse events with renal denervation and extending it into the branch arteries, so this is a more novel technique. And you and your colleagues too have demonstrated the safety of this with imaging follow-up. The second issue is we see the reproducibility of this procedure that we've just discussed, main renal artery as well as distal branch renal denervation. The distal branch arteries being a more susceptible target perhaps to renal denervation therapy. And further, with regard to the numbers, I think a lot of people want to compare what the blood pressure reductions were. Keep in mind that we reported at these sessions when the on-meds study 6-month reductions in blood pressure. In the off-meds protocol, because it was a drug washout regimen and there's a limitation on how long you can keep patients off their medicines, that was a 3-month study. Interestingly, however, though, the absolute reductions by 24-hour office blood pressure measurement with renal denervation in both studies was very similar at 3 months. But interestingly, now we see an even greater decline at 6 months.
Very good. Can you tell us what these studies have told us about perhaps where we didn't execute so well on the HTN-3 study? What are the main things there, what main observations?
It's a reassuring sense and a sense of validation to see these data, both from the off-meds and the on-meds program, because as you've been part of this evolution of the renal denervation, very storied experience or storied path, emanating from the Simplicity Hypertension 3 study that did not demonstrate efficacy with the way renal denervation was performed then, but it was also confounded by the patient population and the behavior of the prescribers and the patients, and our lack of knowledge and awareness about drug adherence and prescription changes, that altogether, when we looked back at exploratory analyses from that experience, when we also revisited our understanding of renal nerve pathophysiology, we embarked on a different procedure with a different technology, the spiral catheter, to provide greater circumferentiality of ablation and extension into the branch vessels. We redesigned the trial with regard to trial conduct, but maintaining the sham controlled blinded procedure. And finally, we changed the patient population to a more moderate but uncontrolled patient population, which in some ways is less polarized, more predictable than that severe treatment hypertension population.
That's really good insights in terms of where we've been and what these two studies add. And of course, as you said, we've got a further study which was reported yesterday, which again adds more evidence independently, showing that there's a strong sign that the denervation is effective at reducing blood pressure.
It raises the issue, doesn't it, that at what point do we no longer require sham control trials, or how do we rethink about redesigning larger confirmatory trials that we're now in the phase with the spiral technology to move forward? I still believe, and I'm interested in your thoughts on this, but that the sham-controlled studies are still very important for nascent developing technologies, because there is no class effect of the existing technologies. One we've learned of in an off-meds protocol with successful results is with ultrasound delivery. The spiral technology, of course, is with radiofrequency energy delivery. Forthcoming studies are looking at technologies that might even include injection of alcohol or drug therapy into the adventitial space.
No, I think you're right. I think we've got data which shows the efficacy in terms of a hypertension level, but as you correctly pointed out, there's many other factors there in addition to efficacy. And for me, one of the big things here is safety. And I think that looking at the spiral device in terms of where most of these denervation procedures have been done worldwide, we know there's a huge amount of data there to support the safety of this technique.
You're absolutely right. And we saw an efficacy benefit that we just couldn't demonstrate, I think, in many ways from the HTN-3 experience. And as I shared earlier, it's a validation to see it here in the off-meds and the on-med study. But you're absolutely right, too, about demonstration of safety, which is oftentimes an assumption, isn't it? And now, in a good way, the focus is becoming one of durability and reproducibility, too. And I think with longer-term follow-up, what we've seen already in existence studies is that the blood pressure reductions are sustained over time.
So there have been many technologies which have looked very promising, then they've gone through this huge dip, and then they've been exciting again, and this realization of where the technology fits in, where its places in the clinical arena, which patients to treat. Where are we now in this journey, David?
It's interesting that with the enthusiasm here at the EuroPCR scientific sessions, there have been sessions regarding how these data will change a clinician's practice. And as enthusiastic as I am about this too, we also, of course, know that we need two large, if not similar, complementary data sets to move forward. One is from a regulatory perspective of still larger confirmatory trials, and the second is studies that will help further inform clinical practice. And to that purpose, we are presently in an ongoing international global trial, you and I among many others internationally, the SPYRAL HTN-ON-MED pivotal trial that will further inform the efficacy and in part safety of renal denervation therapy in patients with uncontrolled hypertension in the absence of medication therapy. And we're presently in the development and discussion of the design of clinical trials that would be related to the application of renal denervation in a larger experience of what we presented here in the ON-MEDS trial in patients with persistent hypertension despite medical therapy. There are many asks from the medical community to seek further, with this type of promise, to seek further data in an area you've studied so extensively, heart failure or atrial fibrillation or other conditions that might be associated with a hypersympathetic signature or state. And I think all of that will follow with either sponsored or investigator-initiated study as this whole field moves forward. But I think in many ways, too, we need to more cautiously think about what trials are needed as the next step for confirmatory pivotal trials to get this into clinical practice.
I think those are all great points. I think the other thing, which is we've spoken about which particular pathology, whether it's heart failure, atrial fibrillation, hypertension, may be good to target and perform trials on. But another thing to think about is which patient group in the hypertension arena would benefit. Yeah. I can tell you from our experience of recruiting patients for these studies and using techniques to identify patients, one of the most common responder groups of patients weren't the HTN-1 and 2 patients, more elderly on many medications. They were younger patients on 1 or borderline 2 drugs, wanting to get relief from hypertension, potentially off medication for a number of years. And I think that was quite a strong message. Us as clinicians, we always often feel that we should be directing where a therapy goes, but actually this way, the patients were telling us where the requirement was. I'm not sure if you've had similar experiences.
Entirely. This has been the conduct of the clinical trials. And you've helped educate a lot of us in how to do this, but it's been a way that we've done trials unlike ever before, promoting the opportunities to be in this study through social media and other venues that we really hadn't, at least heretofore, considered. You raise 2 at least very rarely important points. The first is about patient identifiers and those who would benefit most from the therapy. And I'm excited that this will continue to evolve as the science of renal denervation does. But the other issue is related to this issue that you raise of patient preference. And we observed, what we didn't discuss in detail, is that approximately 40% of the study population in the ON-MEDS trial by urine or blood testing was non-adherent or completely non-adherent or partially non-adherent to their prescribed medications. It was shared equally between the sham control and the renal denervation groups, but it again raises this issue that this was even in the context of patients knowing awareness of the performance of drug adherence testing, and still 40% at all time intervals studied, and it raises the issue that you bring up of patient preference and how we envelope that into the next generation, the next phase of clinical trials.
I think that's a great insight there. I've got just a couple more topics which would be great to discuss. You've got approximately a clinic reduction of 10 millimeters of mercury.
Yes.
Yeah? That's the effect of 1.5 drugs. People ask the question, and it'd be great to hear from you, what does this actually mean for patients? What does this mean for kind of cardiac event risk reduction, that kind of level, that threshold, particularly around the fact that we know compliance of drugs is poor, and we know that renal denervation essentially offers, for the time course we've studied, 24/7 compliance.
Yeah.
What do you think?
I think to begin with, too, as you say, this is this issue with drug adherence also raises one that we wonder how many of the pharmacotherapies that we use for the treatment of hypertension got approved with such dynamic non-adherence rates, don't we? But more broadly speaking, from these pharmaceutical trials and in systematic overviews that incorporate well over 600,000 patients, to put this finding in perspective, we know, first of all, that blood pressure is one of the most important surrogates of a clinical outcome that we have in cardiovascular medicine altogether. Secondly, and more specifically, irrespective of the starting point, whether you're starting at 180 millimeters mercury or 150 millimeters mercury systolic, that a 10 millimeter reduction in the systolic blood pressure, and also irrespective of baseline comorbidities like diabetes or chronic kidney disease, translates to a 10 to 15% reduction in mortality, a 25% reduction in cardiovascular events, and of a similar magnitude, a reduction in stroke as well. These are not only statistically significant, but more broadly clinically meaningful reductions that we're observing with renal denervation therapy. And whether that occurs in the absence of medications or combined or complementary to medications. I think this therapy, if continuing on this successful course, has the potential to have great public health impact.
So my final question is here, do you think often, obviously we've got to demonstrate that a technique is safe and efficacious, but who ultimately should be the decision maker in terms of whether someone gets that treatment? Is it the doctor or is it the patient? Because there's often, let's take coronary artery disease for an example. We may be able to give symptomatic relief for angina with drugs, which comes at a kind of lifelong burden of patients of taking drugs, or perhaps get a similar effect with using stents. And I have an opinion that this should be a discussion between the physician and the patient, and it's a joint decision.
Yes.
I'm not sure if you feel similarly there, but also with regards to renal denervation. What's your viewpoint there? Should patients be effectively given sentence of having drugs for the rest of their life, or should we potentially be looking to give them more choice in this matter?
I like how you describe that in other clinical settings. And as one example, in a study of 1,000 patients taking medications for various reasons, interestingly, 8% of the patient population surveyed in that analysis was willing to give up to 2 years of their lives to avoid taking a single daily pill. It sounds so remarkable and unbelievable, but these are the experiences that we're seeing now in the context of these clinical trials. And I think just as you share, this concept of shared decision-making is really becoming commonplace in medicine, and I think appropriately so. Even in clinical trials in the United States, the FDA regulatory body is asking more for patient preference and patient satisfaction and patient-reported quality of life outcomes. But specific to this, this is really an opportunity, just as you say, where it's not a one-way street. It's not the doctor saying, you need to take these pills. And it always has been, of course, a two-way street, whether the medical community has recognized it or not. This is becoming increasingly commonplace, this concept of shared decision-making for defibrillator therapy, for coronary revascularization of the type surgery versus PCI, or perhaps medications alone. Yeah. And I think this is a very good example of how we start out when we embark on renal denervation for the future.
Good, so perhaps the end of the beginning we are now, and we're now moving on to the next phase of denervation.
Yeah.
David, I'd like to thank you very much for wonderful time we've had here for this brief discussion around the state of where we are with renal denervation.
Thanks for help leading the field too, Justin. Thank you.
Thank you very much. And thank you very much for watching this segment.